Welcome everyone to today's webinar. I am Jessica Kim Cohen with Becker's Hospital Review. We will begin today's webinar with a presentation and panel discussion, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, I am pleased to turn the floor over to Shawn Farrell to begin today's presentation.
Great. Thank you very much, Jessica, and a sincere thank you to Becker's for supporting our presentation on this important topic today. It looks like we have a great audience online, so let's get started. I'd like to start by introducing myself and then introducing our two panelists as well. My name is Shawn Farrell, and I'm the East Region Vice President for Business Development at Avizia. Prior to joining Avizia, I spent over 15 years building telemedicine and digital health programs, and also running clinical departments for large health systems, integrated delivery networks, and academic medical centers. Marty, Dr. Dorfler, can you tell the audience a little bit about yourself?
Sure. Dr. Martin Dorfler. I am the Senior Vice President for Clinical Strategy and Development and the Associate Chief Medical Officer for Northwell Health. I'm a critical care physician by background. Spent about 20 years in practice and research, both at the bench and clinically. Left practice in 2000 and spent 10 years with what is now Philips VisiQ, and have been here at Northwell since 2010, responsible for both clinical transformation across the health system, as well as our telehealth strategy and operations.
Great, thank you, Dr. Dorfler. Dr. Fleischert, can you share your story with the audience?
Sure, thank you very much, Shawn. Peter Fleischert, Senior Vice President and Chief Transformation Officer for New York Presbyterian. I've been with New York Presbyterian for the past 11 years, trained as an anesthesiologist, have served different roles in the organization, quality and patient safety, Vice Chair of Anesthesiology, Chief Innovation Officer, and most recently this role, where I cover our enterprise, EMR, consolidation, our pharmacy operations, telehealth operations, some work in artificial intelligence and machine learning, and some integration in a new facility that we're going to be bringing live in April. Thank you very much.
Thank you, Dr. Fleischert, and also Marty. I also want to note that Jessica Zhang from New York Presbyterian has joined Dr. Fleischert in this presentation, and will be coming into the presentation a little bit later because as usual, Dr. Fleischert is triple and quadruple booked and needs to run to another activity. So I'd like to get started in this first segment of the webinar. Folks will hear from both of yourselves as industry leaders as you describe how your respective organizations are leveraging telehealth to make a meaningful and measurable difference in the delivery of care. Dr. Fleischert, New York Presbyterian in the New York metropolitan area is one of the nation's most comprehensive integrated academic healthcare delivery systems. They're dedicated to providing the highest quality, most compassionate care and service to patients throughout the New York area, but also nationally and around the world. Can you tell us more about New York Presbyterian's telehealth journey, please?
Sure. Thank you very much again. So as you mentioned, we feel that telehealth is critical and a core part of our operations. We historically have not done a lot in telehealth. It is only about in the past 2 years that we've built our telehealth program. A core component of that has been that we really felt that we did not want to have an episodic transactional telehealth program, and we wanted to have a coordinated care platform. And in doing so, we felt that it was critical to have a comprehensive suite of services. So as you'll see on the next slide, we built what we call New York Presbyterian OnDemand, which is about 50 telehealth programs that have been built over the past 2 years. everything from primary care to second opinions, all the way to a mobile stroke unit with a CAT scan in the ambulance. And we feel that a comprehensive program is critical. I'm just going to go through on the next slide a couple brief highlights of the program. One is second opinions. We feel it's critical for patients to be able to go online, to be able to register and request for a second opinion where we can collect their medical records, their imaging, be able to bring that in an asynchronous fashion so that we can be able to deliver a second opinion to patients within a day or two. Currently, we have about 300 providers from Weill Cornell and Columbia doctors in about 80 specialties that can provide those second opinions. The next service, really lending more to this conversation today, is really around synchronous visits. This is an area where we've been spending a lot of time in leveraging video technology. One of the programs has been putting in video visits in our ED. This is a challenge. It's a big challenge, as my colleague from Northwell will probably admit, in terms of patients coming into the EDs, especially now with flu season. We basically created a workflow where a patient comes into the ED and is seen in triage. And when they're seen in triage, they meet all the core requirements, but ultimately they are given an option of an in-person visit or a virtual video visit. In the in-person visit, our time from admission to discharge is approximately 2.5 hours. With our video visits, patients go on to a room and they basically do and complete a video visit with a board-certified doc from Weill Cornell or Columbia doctors. And from admission to discharge, the time is approximately 30 to 31 minutes. And this has been a very big patient satisfaction. Patients have thoroughly loved it and enjoyed it. We've done roughly 8,000 to 9,000 of these a year. We've been able, because of the model, been able to scale it to over 4 hospitals. Ultimately, we feel that this is a better way for us to take care of lower acuity symptoms, allocating more space for higher acuity, being able to take care of patients timely and efficiently, and we monitor all the outcomes as well. You'll see on the next service, though, we want to also provide that same capability from home with on-demand visits. So we do that in 4 states, New Jersey, Connecticut, Florida, and New York, so that you can basically get that same type of express care visit by just going on to the NYP app. You can go onto ZocDoc, you can go onto a Samsung phone and it's pre-installed, and basically get a Weill Cornell board-certified physician or pediatric specialist in about 60 seconds to be able to see them for a variety of conditions and have those visits. And I think we'll talk about that later today. But ultimately, in the next service, in what we call our peer-to-peer, we think this is a big opportunity for telehealth. As you've heard and Shawn introduced, we are an academic integrated healthcare delivery system consisting of 4 divisions. One is New York Presbyterian Hospital, which is our academic centers with Weill Cornell and Columbia. Then we have 4 small and large regional hospitals in Hudson Valley, Lawrence, Queens, and Brooklyn Methodist. And then also a employed physician group and a population health management division. So you can imagine the potential with peer-to-peer connectivity. Something like psychiatrists that are in short supply, being able to provide psychiatry consults to all of our EDs. It is a challenge. It could take a patient in a regional hospital up to 24 hours to see a psychiatrist. And we were able to launch telepsychiatry where we can get that time to about an hour to be able to see a psychiatrist. That expands to a lot of other services, teleneurology, telepediatrics, telepharmacy, to really be able to expand and have people operate at the top of their license across multiple facilities. And we feel that's really a big driver of telehealth and the opportunity ahead. One of those services traditionally is Telestroke, and we think that that's critical. In teleneurology, we've seen about a 7-minute time reduction for a patient coming in to see a neurologist. But ultimately, we wanted to expand on that, and so we launched a mobile stroke unit that actually has the CAT scan in the ambulance. And this provides the capability when you're calling 911 that if it's signs or symptoms of a stroke, we can deploy an ambulance, and ultimately the patient can go into the ambulance and be able to have a CAT scan and be diagnosed and treated on the ambulance. So this is something we feel pretty significantly reduces that time to treatment, anywhere from 40 to 70 minutes. But it's a challenge because it could require a neurologist to be on board every ambulance. So it's another opportunity for a teleneurologist to be overseeing multiple ambulances. So this is just some highlights of some of the programs to date and some of the outcomes that we've seen and what we think is the potential for a lot of opportunities for telehealth. None are new or novel to us. Many have done this, and many health systems have been leading the way in this, and we think it's critical to the way we operate moving forward. We feel it's so critical. On the next slide, you're going to see that we've grown. We've done about 15,000 of these visits so far, about 600% growth in 2017, with about 700 doctors providing these care. As I mentioned, we've now expanded this out on Samsung devices, on our own MYP app, on Apple and Samsung and Android devices, working with ZocDoc. And then the latest, we've actually also put this into Walgreens, so that there's 2 locations in Lower Manhattan where you can walk in and get your blood pressure, heart rate, pulse ox, and see a video visit with a provider. And it's another opportunity which expands into the last part of remote monitoring, which we think is a big focus for the year. And so we think it's critical as we move forward. Ultimately, we want to improve our operations within the hospitals, but also make it more convenient for patients to either access at home on their phone, tablet, or in a Walgreens.
Thank you so much, Dr. Fleischert. An incredible overview of a rapidly growing program that clearly has shown significant success. So thank you so much for that overview. I'd like to switch now to Dr. Dorfler. Dr. Dorfler, Northwell Health is one of New York State's largest healthcare providers and private employers. Its mission is to improve the health of its communities with a focus on prevention, wellness, and providing the full continuum of diagnosis, treatment, and aftercare services. Northwell is striving to define tomorrow's healthcare, and part of that vision includes telehealth. Can you share some of us the detail on your program activities?
Yes, thank you. And Peter, I enjoyed hearing your program description. I'm aware of some of what you've been doing, but applaud the success you've got there. For the audience, I think what you're going to hear as I talk a little bit about mine is parallel journeys with different components, but philosophically largely aligned. We are the largest healthcare provider in New York. We're spread out across 23 hospitals and 6 different counties, if you count the 5 counties of New York City and Westchester and all through Long Island. So from one end of us to the other is with the traffic hours on the road in many circumstances. And so for us, telehealth is a critical component. We began most of our work focused on the facility side of things. And so intensive care was one of the first things that we did, Telestroke, behavioral health, and I'll talk about some of those when I get to the next slide, not to switch it yet, Shawn. But recently we have added in an e-hospitalist program. We own skilled nursing facilities, and we have connected our telehealth sensor to our skilled nursing facilities. And then the next phase of this, which is the one that we're most ingrained with the Avizia team with, is our direct-to-consumer, where we do see on-demand care in a bring-your-own-device world, and really not as the episodic care of limited to an urgent care visit or those one-offs, but really embedding this into the overall continuum of care. And my goal over the next couple of years is, in essence, to fully virtualize the entire health system. Next slide, Shawn, please. So this is a little bit of us. You can see some of our geography. These are our hospitals. We have strategic alliances that go well outside the area. We just announced today an alliance with hospitals in Western Connecticut. We have an alliance with Crouse Health System in upstate New York, and we will be connecting our telehealth operation to all of these in one manner or the other. Next slide. The core of what we have in place, and Peter said that their journey is about 2 years old. Our journey is about 4 years old, focused somewhat differently at the outset. We began with our EICU program. EICU has been up and around the country for some time, but ours began here in December of 2004. We now are in 12 ICUs and 11 of our 23 hospitals, covering about 160 patients on any given day, and have resulted in a severity adjusted mortality rate in those covered units of 20%. So we're quite happy with that. We've then taken that same platform and infrastructure and leveraged it and built it out farther. So we put mobile carts on that infrastructure in all of our emergency departments. We've then wired the homes of our stroke neurologists. We have 3 different teams right now on our Staten Island, Lenox, and Manhattan, and Central region. Those will centralize into one team that is always on 24/365 come July. We've also resulted in significant reductions in door-to-needle time with TPA and increasing the frequency with which we're giving TPA to patients, which, as Peter mentioned in his their stroke work, which varies somewhat from how we've approached this, is significant, very important in reducing the amount of brain damage. Very importantly, we also have a telepsychiatry program. It's been one of our most successful programs. We're seeing 4,000 emergency psychiatry cases per year right now. We are in every one of our emergency departments. We have reduced the average wait time to see a psychiatrist from 12.5 hours to 45 minutes. Half of those patients are hospitalized. We've actually been working with the Office of Mental Health in the state of New York and have accelerated the paperwork and have virtual psychiatrists able to complete the paperwork to get patients admitted as necessary, even in hours when the receiving unit doesn't have a psychiatrist in it. And then we're adding in our trauma units, our neurocritical care, pediatric critical care, our pediatric emergency department. We have a children's hospital here. From my peripheral hospitals, we send 800 kids per year into the children's hospital out of the emergency departments because we believe that they may need admission to a children's hospital. Half of those are treat and release once they get there. So as we're rolling out the pediatric connection into all of our EDs, we expect to reduce that. Let me flip to the next slide, though, here and get into where we're going in the direct-to-consumer space, which is our work with the Vizia. And here we are actively, we've pushed out the Vizia platform. We've transferred the telepsychiatry program onto this. We've begun working with our employee assistance program. We've begun working with our employee health operation. We have several managed care areas and our population health. Our house calls program is evolving to have greater use of this, but the 3 dials on here really show the vision of where this is and where it's going to go. We believe that the future is any patient, anywhere, with any provider. And even beyond providers, as you see on here, the diabetic educator or the social worker, and not the strict urgent care model that is more prevalent in the telehealth space nationally. But if somebody, my children are all grown, but hypothetically, I've got a 10-year-old child who saw their pediatrician 3 months ago, who now has a fever and a rash. Why don't I have them see their pediatrician who knows them, can opine on what's going on and say, I should see them in the office, they can go to school, keep them at home. We really see this as where the continuum of telehealth is going and needs to go. And within the next 12 to 18 months, as I said, we expect to fully virtualize all aspects of the health system. That's not saying every provider and every patient will have telehealth, but every service that we provide will be available in the telehealth space from some element of our health system. Let me stop there and let this move forward.
Thank you so much, Dr. Dorfler, and thank you both for providing such great details on your programs. In this next segment of the webinar, we'd like to focus on some findings from Avizia's Closing the Telehealth Gap research report. In 2017, Avizia and Modern Healthcare partnered to conduct two separate surveys, one targeting consumers and another focused on healthcare executives across the United States. In the consumer survey, 403 consumer respondents responded to that survey. In the healthcare executive survey, there were 677 respondents to the survey. The survey findings were considered accurate to a 95% confidence interval, and we'll share a link at the end of this webinar for those who want to download the complete report. And so for the remainder of today's webinar, we'd like to focus on interpreting those findings, exploring consumers' awareness and use of telehealth, what's driving today's healthcare organizations' telehealth strategy, some telehealth use case trends, and finally, some opportunities and challenges for the future. First, we'd like to look at some of the consumer trends and attitudes our research uncovered. Of the 400 consumers polled who responded, just under 20% have used telehealth. This utilization rate is consistent with other larger surveys that have been conducted in recent years. For those who use telehealth, what drives them to use it? Well, 55%, more than half, felt that they received care faster with shorter wait times. 43% reduced their out-of-pocket costs. 25% gained better access to care through specialists or urgent care, primary care clinicians. And 16% felt it improved their experience. Conversely, that means that of the 400 consumers who responded, over 300, or 82%, are not using telehealth. More than half said they just hadn't had the opportunity. A third said they prefer in-person encounters, while some were concerned about the out-of-pocket costs and whether or not it was covered by insurance. And others had just frankly never heard of it. So I wonder, I'd like to ask Dr. Fleischut, what do you make of these numbers? Are you surprised that 82% have not used telehealth and that 10% have never heard of it?
So this is Jessica stepping in for Dr. Fleischut. I would say this is definitely in line with our experience. Awareness has been one of our biggest challenges in expanding telemedicine. But what we're doing is really making telehealth a part of our care delivery standard, regardless of whether you're in the ED or in an outpatient setting. And our approach is really to try to engage providers and really our patient base to improve this awareness.
Thanks, Jessica. Yeah, I think that the majority of the consumers who responded to this survey probably, those that had experienced telehealth probably had experienced it in an urgent care setting where it was more transactional in nature. Dr. Dorfler, these reasons for not using telehealth resonate with you?
Yeah, I think the telehealth offerings that the patient community could even be aware of have been very limited. I mean, the virtual urgent care is the one that even when we talk to payers, they see telehealth as largely pigeonholed into that space. The limited number of individuals who have had a stroke probably don't even recognize in many circumstances with everything else going on in their illness that's there. People who've been in ICUs covered by EICU programs may not be aware of it, but even there, the population would be quite small. I think until we have integrated this into routine care and people are seeing their own providers via telehealth who are offering telehealth as a component of how they deliver care to the community they serve, we're not going to really see this change.
Great point, Dr. Dorfler, and I agree completely. Jessica, any other thoughts about ways that we all might be able to positively impact these numbers and get more people aware of and using telehealth? What are some of the things that NYP is doing to raise awareness in their patient communities?
That's a really good question. One specific example I have in mind is our Express Care program. So when patients are actually coming into our ED, they're offered the telemedicine option, as part of their routine care. So you have the option of waiting in the ED, for a portion of time, or you can be seen immediately through our telemedicine platform. So, just by offering those two services side by side, it really opens patients' minds to, oh, this is an option for me. I'm going to try it, and most of our patients have had great experiences and have spread the word just through that.
That's great. Thank you so much. I want to highlight a separate RAND Corporation study, which was released in March 2017, that revealed that while there was an 88% growth in direct consumer utilization from 2011 to 2013, it noted that only 12% of those visits actually replaced an in-person visit. And so the authors conclude that the majority of these visits are not substitutive, and as a result will likely increase overall healthcare costs. Dr. Dorfler, a bit of perhaps a charged question to you, but is this a paternalistic view of medicine? Aren't all healthcare encounters important if they result in a healthier outcome for the patient, and whether that's a virtual urgent care visit or remote patient monitoring activity that might occur with chronic patients at home?
I think the key to your question is the way you phrased it is all healthcare important if it results in a benefit to patients. There are a lot of walking well who are worried well, if you will, who will seek healthcare services in circumstances where it may not have any benefit to them. And if this 88% growth represents more of that, which I have some concern the virtual urgent care space as a limited area has the potential to do, then that would indeed occur. That said, I think that if you come back to my provider who already knows me and understands my care, and I can have a virtual visit where the continuum of care is maintained, I think we'll see an entirely different set of circumstances. Now, let me just add on, the fact that these are things that were not provided care before and are now may parenthetically be valuable. We know with the expansion of Medicaid, and this is not to be political on this, but with the expansion of Medicaid, populations that didn't receive care who suddenly do have better outcomes. And some of what's occurring in the virtual care space could be analogous to that as well, where care that was beneficial but not available now became available, and that benefit is accruing to individuals, and that likely represents some of that growth as well.
Great points. Thank you so much. Jessica, a question for you. What is, in your opinion, what's the right role for telemedicine in meeting the patient where they live, work, or travel? Is a transactional relationship at a lower price point than the ED or urgent care good enough, or is there more to it than that?
So I think there's definitely more to it. I think this particular study is probably more focused on urgent care and really those transactional direct-to-consumer cases. I think our approach at NYP is really to meet the patient, where it's convenient for them, and to really virtualize the entire continuum of care, from ED visits through outpatient visits to remote patient monitoring and follow-up. So we really don't see our approach as, one-off urgent care visits. We really see virtualization in really every aspect of our care.
Great, thanks so much, Jessica. So I'd like to shift now to the provider healthcare system healthcare executive survey. Again, 600 healthcare executives responded to our 2017 Vizia Modern Healthcare Survey, and I think that revealed some interesting trends as well. While this is not a true tracking survey, it did ask the same questions to a group of respondents from 1 year to the next. So I think it reveals some interesting and changing attitudes towards telehealth that are worth noting. First trend is that the number of programs citing consumer demand as the reason they launched fell by about 50% from 2016 to 2017. While at the same time, the number of programs citing expanding access and reach rose 75% from 2016 to 2017. My take on this is that many health systems in recent years have invested in those direct-to-consumer urgent care programs in response to what they perceive to be consumer demand. And in reality, based on all the numbers that we've just seen and talked about, consumers still see many barriers to telemedicine care, which we described earlier. And as a result, there's been low utilization of those programs. And that's due to awareness, uncertainty, and as a result, health systems experienced unsatisfactory results and return on investment with these programs. So today, I think that in my experience, health systems are getting much more sophisticated in their telehealth strategy as they continue to consolidate vertically and horizontally. And you just heard Dr. Dorfler mention some new affiliations that they're engaged in with organizations in Western Connecticut. They're developing strategies to improve access to care across broader geographies. And telehealth becomes a really critical enabler of those larger health system strategic goals. So Dr. Dorfler, clearly, this is consistent with Northwell's approach and telehealth philosophy, right?
Yes. Is there a question in there beyond the yes?
Would you like to elaborate on that? Is there any other way that do you view telehealth as an enabler, or do you view it as a strategy in and unto itself around the innovation pillar, or is it an enabler, or is it both?
Well, I think it's clearly both, but I think that it's more an enabler. We are, as I said before, a very large organization, spread out, large physician network, providing care across a very large population and community. All of the things that are on here drive our daily activities. We are seeking to provide the best outcomes at the lowest cost possible. So I don't see how you can separate those two. We do believe that in order to be successful, we need to serve the community where it is. People who work in Manhattan live in Western Connecticut as a point, and so those individuals are in both those locations. We need to reach them in both of those locations. I think part of what you see on this slide, though, just to address it, is the shift in perspectives and recognize that right now, and it's sort of interesting that NYP and ourselves are on this together without having, we're direct competitors if anybody out there wants to know in the market, but with no collaboration of any kind, and even talking to each other about what we're doing, we've at the same time identified a role for telehealth in the overall continuum of care and a need to virtualize what we do to extend out and best serve our communities. I think that says a lot as to where this is going and needs to go. And I don't know what the pressures are on us here that we've done this in this sort of same time frame, where there are other areas of the country that certainly have, but the vast majority of the country is looking at this in a siloed approach of I'm doing stroke or I'm doing behavioral health or I'm doing urgent care, not really putting together the entire continuum of care.
Thanks, Dr. Dorfler. Jessica, any different perspective from NYP? How have these different elements impacted, influenced, affected your overall strategy at NYP with respect to telehealth?
That's a good question. I actually sort of wanted to echo Dr. Dorfler's perspective on really improving patient access. One of our really big goals is to improve access from a provider efficiency perspective as well as patient access. So I think as we start to look at ROI and utilization among patients, we're trying to develop other metrics beyond just readmission or really concrete metrics to other things that we want to look at, like patient experience. I think even with the mobile stroke unit, we're able to develop a lot of really specific clinical outcomes that we can measure, before and after implementation of telehealth. So I think our strategy is definitely in line with some of the trends that you see here on this slide.
Thanks, Jessica. Great observation. Let me switch to the next slide. Another observation that we had from the data is that while in the past the most common programs implemented were Telestroke, behavioral health, and EICU, the growth of those programs over time seems to have slowed and plateaued a bit. Obviously, organizations are still adopting those programs and adding those programs, but that pace of growth and addition has slowed. And we're seeing a rapid rise in programs focused on pediatrics, including school-based telehealth, remote patient monitoring activities, chronic disease management, and patient education and training. Question to both Jessica and Dr. Dorfler, and maybe Jessica, we can let you go first this time. Why are we seeing this shift? What potential impact do these programs have on patient access, outcomes, and costs? And what might the external influences be that are driving organizations like yours to move beyond this, to think about other programs like pediatrics, chronic disease management, and remote patient monitoring?
I think that, this shift is sort of a natural evolution of how we do telemedicine at NYP. I think we're moving away from transactional telemedicine to something that's more coordinated and really, again, expanding our access across the continuity of care. And specifically with school-based telemedicine, I think this is something we're actively working on. We're able to expand provider capacity and reach more students and increase access among students by implementing telemedicine. And so, we've really laid the foundation and the groundwork in our infrastructure by starting out with programs like Telestroke, behavioral health, and EICU programs, and really taking that to the next step is expanding in programs where there's a serious access problem to be able to meet the patient's needs.
That's great. Thank you. Dr. Dorfler?
I think there's a combination of things here. First, I don't think that the top three have plateaued quite to the degree they look on this graph. I think that when you look around the country, places are continuing to do this. But I think one of the major pieces I would point out here is the changing technology platform involved in these. The EICU is hardwired into ICUs. Stroke programs, in many ways, are similar. You're in an emergency department where you have highly reliable technology. And the psychiatry part of here is not community behavioral health as much as it is, I know ours is, and I believe, if I heard correctly, NYP's program is mostly focused on the emergency department on those acute events. So putting technology into a incredibly well-defined arena that we own and operate, such as an emergency department or an intensive care unit, around things that have clear return on investment, at least from a clinical standpoint, like stroke, intensive care, et cetera, has been much more easily done than reaching patients and families in their homes around childhood diseases or chronic diseases or the like. And part of what we're really excited about here, and part of our plug to Avizia here, working with the Avizia team, is that we do believe that technology has moved to a point that we are prepared for a bring your own device world, be able to meet patients where they are and provide a reliable service over reliable technology. And that was not true 5 years ago. And so the chronic management, the training, the pediatrics, I don't think we were positioned to be able to do those, whatever the market demand and value might have been 4 or 5 years ago.
Excellent. Thank you, Dr. Dorfler. Before we get to questions from the webinar participants, and I do see a long list of questions, and we'll do our best to get to some of them. I want to ask you both, this is the one last slide. I want to ask you both if you could share one opportunity you're excited about and one challenge that worries you. Dr. Dorfler, why don't we start with you?
The big one for us right now is the e-skilled nursing facility work that we're beginning. We really believe there's a tremendous need. It's an underserved population. The new CMS rules that are going to actually penalize the skilled nursing community for readmissions is giving them real reason to want to work with us on this. And so we see a real opportunity there, and are going to be very aggressively working in that space right now and over the next 12 to 18 months. The biggest challenge of all of this right now is reimbursement. It's all over the map. I'm not in a CMS underserved or a Medicare, rural designated underserved area, so I can't bill anything to a Medicare patient. New York State allows me to bill Medicaid as long as I'm billing them in other healthcare facilities, and the governor said he'd like to see that change, so maybe it will. And then I have commercial coverage parity, but not payment parity, and the payers want to pay me significantly less for the same 15 to 30 minutes with a provider by putting them virtually in someone's home than having them in the provider's office, and that's nonsense. I can't run a business that way. And so tremendous opportunity in areas where we have just not historically served certain communities at the highest level possible, like skilled nursing, and tremendous, risk and problem around the real uncertainty in the payment environment.
Thank you, Dr. Dorfler. Jessica?
Sure.
One opportunity and one challenge.
One opportunity, one challenge. I think the one opportunity we're really excited about is really expanding specialty access to support our primary care practices. Whether that's using platforms like Avizia, through a peer-to-peer model, we're really excited to expand specialties, especially for specialties that are high demand with long wait lists. We're excited to use new ways of connecting patients and really maximizing provider efficiency. One challenge we're worried about, reimbursement is definitely on the top of our list, but I would also add consumer awareness about telemedicine. I mean, in your earlier slide, it's still a very small percentage of consumers know about telemedicine as an option. So, we're still going to try to, market and partner with external and internal partners to really get the word out that, this should be a standard of care.
That's great. Thank you both for both of those insights. I do want to ask one follow-up question from a panelist, from a participant that is related to payment and business models. Obviously, the payer environment has a bit of uncertainty with it, and I think it's fair to say there's a lot of confusion as to what is paid for and what isn't paid for. But another way to think about these programs, and this has been a traditional model for the EICU model, is to look at the return on investment either through cost savings based on better, faster care, better treatment plans, or through revenue generation associated with efficiency. So in the EICU model, you might have a shorter length of stay, and therefore you can turn that bed over in a high occupancy unit for that next paying patient. Same thing goes in the emergency room when you're doing fast tracking behavioral health or fast tracking express care patients. So I wonder if you both could maybe talk a little bit about those alternative business models that aren't focused on the transactional payment for that particular event, but taking the broader view.
So we've done all three of the ones you laid out. Telepsychiatry pays for itself for a variety of mechanisms, as you said, freeing up that ED bed, the EICU increased throughput. Stroke may actually cost us money. Shortening or decreasing the degree of brain damage in a stroke translates into a potentially lower DRG, and I may lose money on that. So the business model has to be around your mission. We sit back and say, we don't care if we lose money on that. We're going to provide the best care we can to our communities. But there's a real limit on what you can do paying for things just on efficiency. Taking care of a child at home when you're going to get paid nothing and it's going to take 30 minutes of a pediatrician's time. When the child comes to the pediatrician's office and they get paid something to help support the office, I can't do those things. So by having this require non-revenue-based business models, we're all moving this forward as well as we can. Certainly in the risk-based model, you can do a lot of things there when we own the premium dollar, if you will, in an insured market or things along that line. but a huge amount of healthcare delivery into the communities is still, at least what we want to try to impact. We pay for care that occurs in certain locations based upon it being in that location. And that's nonsensical in terms of actually delivering care under circumstances where it's providing value to patients, and where the value to patients may be significantly greater by having them not have to get into their car, spend a whole bunch of time looking at the windshield in traffic to get somewhere to spend 15, 20 minutes with a provider, only to repeat that going home again. Why should the provider be paid less for that episode of care than if they delivered it in the patient's home? So the value to the find other ROI there is there, and we're all working on that. We're going to push it as far as we can, but there's a limit that you can go to with that model.
Great point. Thank you so much, Dr. Dorfler. I have another question from the audience here asking about capacity. Can you explain how you manage the capacity? And I'm assuming that they mean clinical capacity for executing on these programs. Do you have a centralized group of providers that service all of your sites, or are you trying to load level the providers you have across the facilities?
Our approach is really to have clinicians be dedicated to the telemedicine service that they're working on. We find that that's where we gain the most efficiency if providers can block off that time. So from a capacity perspective, that's typically how we staff.
Yeah, I would agree. From the things that we have up, our stroke, our EICU, our e-hospitalist program, et cetera, those are dedicated providers who are responsible for doing nothing but this for that unit of time. As we move into the direct-to-consumer space, we intend to have remote care, self-scheduling, and the like, and to fit this into the provider's calendar, no different than any other care paradigm, and then it will be managed by that practice in the same way that they manage the flow of patients in and out of their doors.
Excellent, thank you. Question from one of our audience members: do you foresee any future for tele-rehab services such as physical therapy?
Scheduled for a knee replacement in the not too distant future, I will answer that unequivocally yes. We've actually partnered with one company that provides YouTube type videos to guide people through some rehab activities and things along that line, whether or not your knee is bending as well as it's supposed to, or you're stepping upstairs as well as you're supposed to. New York State just included physical therapy as one of the reimbursable services under the telehealth law here. I unequivocally see that as that occupational therapy, speech therapy, things along that line as part of the continuum that will be available by telehealth as we progress.
And I would also say yes, on our end, we've had great success in orthopedic follow-up visits. Patients that have traveled a long ways to New York Presbyterian to have their surgery certainly don't want to come back soon after for these follow-up visits. So the fact that we can offer these telemedicine visits has definitely improved patient satisfaction, and we've had great success there.
Great, thank you both. Along those lines, great question here. What does program development look like for your organization? So maybe we could start with Jessica. How do you evaluate programs that are coming into the pipeline, into the funnel? I'm assuming that you've got more programs than you can possibly implement at a given time. And so how do you evaluate those programs? How do you prioritize them, select them? What are the criteria that you might use? And maybe for those that there aren't a lot of programs in the pipeline, how do you generate a list of programs that might be good candidates?
That's a really good question. Well, I can certainly tell you that we have no problem generating new program ideas. We get several every day. And it's definitely been a challenge managing new programs that are coming through our pipeline. One thing that we found to be really effective is coming up with a really thorough intake process that our team manages And so this includes stakeholders from IT, clinical leads, finance, all of our corporate functions to be able to evaluate each program, what are the needs and the resources that we'll need to have in place, and what are the impacts of this program. So I think having a standard intake process for all of these new use cases can really help you, manage, what we need to put to the forefront or something that we should save for a later date.
Thanks, Jessica. Dr. Dorfler?
So I'll start with you don't have much going on and how do you get it started, and then echo Jessica. Success begets success. Start somewhere with something that you believe you've got the resources for and the capability of executing. To some extent, it comes back to what problems do you have to solve, and then that's generic. It's not related just to telehealth. Is telehealth a tool? If you take something like stroke, do you have the available neurologists there? If you don't, that's not the problem to take on right away. If you have the behavioral health staff around and that's a problem, align your resources with your problems needing to be solved and begin there. As there is some success with one program or another, I agree with Jessica, the number of new ideas will start coming out of the walls at some point as folks are looking at how they deliver the care that their specialty or their clinical domain is trying to deliver to the community, and they see that these tools exist and might fit into what they're trying to achieve. They're going to knock on your door. I do think it's very important to have a structured intake process. We look at what problem they're trying to solve, how likely it is to be solved, what tools they need, where those tools are in our development cycle, how well they're deployed in the arena that they're already at, and go along that type of a matrix in figuring it out. In the end, it's a very small group on our side that says, here's the queue and here's how they're going to flow out of this. I actually lead that, but has input from a number of senior leaders and then a number of operational management level folks as to how to stratify that queue.
Thank you very much, Dr. Dorfler. I think we might have time for one or two additional questions. Depends on how long the responses are. But I want to ask, one of the questions was related to KPIs. How do you measure success? Jessica, you and I have worked together on some of the NYP programs, and I think the biggest metric for success for you all, because of the scope and scale of your programs, is volume of visits, number of visits that are occurring. What other KPI metrics do you use? And then maybe Dr. Dorfler can give some of his.
Sure. There are definitely other clinical KPIs that we actively track. We compare, like the metrics that Dr. Fleischert presented earlier. We measure throughput through our EDs. We measure response times for our mobile stroke units. And we're also monitoring, our patient experience, checking in with patients and surveying patients on whether they had a good experience through our program. So I think, we have a combination of clinical KPIs that we actively track, as well as customer satisfaction KPIs that are important to our metrics.
Thank you, Dr. Dorfler. Anything to add?
Yeah, well, I'll largely echo that, other than to put, and Jessica said this, but wasn't as specific about it. For every one of our programs, we sit down prior to launch and specifically identify what it is we're going to measure that we believe this is going to impact, and as well as to measure areas where we think there could be adverse effects, to make sure that we are tracking and avoiding those, and then roll them into the metrics that are being used across the health system, like Press Ganey, and just routine finances and patient experience straight away.
Great. I think we have time for one more question, and I will fully admit that this might be something in the radio world that they call a big market tease, because this is a topic that we could probably spend another full webinar on. And it has to do with the EMR or EHR systems. And the question is, are you providing telehealth services straight out of your EMR system? We all know that the EMR is the operating system of a healthcare entity. It is the tool that clinicians are in almost every day, all day, for better or for worse. And they want to drive as much activity through the EHR as possible. In the past, all of our much of our work to integrate with EHRs has been moving bits and bytes of data back and forth that are meaningful in the form of, scheduling visits and orders and other aspects of data movement. Recently, there's been a lot of activity, and Avizia has been very involved with all the major EHR systems around true workflow integration, where the telehealth platform can be launched from within the EHR. And the EHR companies are also developing some basic, simple, rudimentary capabilities as well. So wonder if I could get both of your perspectives on the EHR as a telehealth platform.
Sure, I can start. I think integration is definitely a huge concern of ours. I think, unfortunately, right now there's no one-size-fits-all telemedicine solution that's integrated into our EMR. So I think in the long term, we want there to be as much integration as possible so providers don't have to log in and out of different systems, and we want the information to be consistent and to have integrity. But truthfully, I think we're still working towards that. We haven't come up with the perfect solution.
Mm-hmm. And I think one of the challenges, too, with organizations the size and scale of yours is you may not have one EHR. And so that in and of itself probably presents a challenge. And you really need something that's going to be able to bridge multiple EHRs, especially as you grow and start to integrate vertically and horizontally. Dr. Dorfler, anything to add?
Yeah, well, as you know, Shawn, because we're working with you on this, we believe very firmly that this all needs to be in context. And we're in the process of working to create the patient access through our digital patient experience portal so that the patient will go online and be able to schedule face-to-face and virtual visits in one location, as well as be able to conduct their virtual visits from that same linkage. And from the provider standpoint, we've already got it so that the logons into our Avizia Telehealth platform are the global logons for everything else within the health system, so we don't have to deal with password control and all the rest of that. And they're in the process of integrating that into our ambulatory EHR as we speak right now. Our intent is by the end of 2018 is to have the providers working in context so they are within the EMR, and we, as a 23 hospital system that added another formal hospital to our system only a month ago, will never be on one EMR, certainly during my clinical lifetime. And so we do believe that it needs to be a standalone system as opposed to one that's built into the EMR that is across the entire place, but we have integrated it into each of the EMRs that we're using so that there is a consistent provider and patient experience to the extent possible.
Fantastic. That's a great way to end this hour. In closing, I'd like to thank all three of our panelists for some really great insights, and I want to thank the audience as well for some great questions. Just a reminder that you can download the full report at avizia.com/gap17, and I'd like to turn it back over to Jessica from Becker's. Thank you.
Thank you so much. Again, I wanted to thank Shawn, Dr. Dorfler, Dr. Fleischut, and Jessica for their excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.